Good evening. Welcome to the Bessie Smith Cultural Center. And welcome to our third Minority Health and Health Equity series. Tonight we will have a discussion on advancement in stroke management. And we're certainly looking forward to this discussion. This will be our third one, I believe, and we're excited about that. We missed November, but we're in December. It's a little chilly outside, but we're going to warm up in here, okay? Thank you for being here. Tonight, our moderator will be Dr. Cornelius Mance. He's a neurologist, and our panelists are Dr. Cleopatra Thurman, vascular neurologist, and Dr. Larry Gibson, a neurologist. We're excited to have them talking about this important issue with the medical, those medical issues that affect the African American community especially. So we are hoping to learn a little bit about stroke management and a little bit about the things that cause stroke. We're thankful for our sponsors, and that is the Erlanger Medical Center, or Erlanger Health Systems. We're certainly happy to have them with us. The Mountain City Medical Society, the City of Chattanooga, and of course the Bessie Smith Cultural Center. Now we are live streaming, and if we're live streaming, it's www.bessiesmithcc.com/livestream/. Okay? So if you send it out to anybody, just tell them bessiesmithcc.org/livestream/. For more information on the Bessie Smith Cultural Center, the Chattanooga African American Museum, because we want you all to come back and see what we have to offer outside of these panel discussions, you can go to www.bessiesmithcc.org. And you can also call us at 423-266-8658. Okay? Now I got all the house cleaning stuff out of the way. We'll get started. But before we get started, we have a special guest with us. His name is Dr. Robert Maxwell. Dr. Robert Maxwell is a physician at Erlanger Health Systems. He's going to come and talk a little bit about a trauma study that they're doing that will be coming up at Erlanger. And once he finishes, Dr. Mance will take over and get started with the panel discussion.
Good evening, everybody, and I'd like to thank Elizabeth and Elijah for working me in the front of your meeting this evening. Hey, Will, and I just wanted to come down tonight and talk to you all about a study that's going to be conducted at Erlanger. I'm Robert Maxwell, the Trauma Medical Director at Erlanger. And next slide. Erlanger has been asked to participate in this international study on a blood clotting compound. It's known as the TAP trial, and that stands for trauma and prothrombin complex concentrate. And this, next slide. Next slide. There's going to be 140 hospitals throughout the world participating in this, and we need to accrue 8,000 patients to tell a statistical difference between giving this medication and standard care. The company sponsoring the trial has established an independent data and safety monitoring committee, and there'll be periodic interim analysis, and this committee will make sure that the study is being conducted as it's intended to be conducted and that there won't be any unrecognized adverse effects happening to patients that are enrolled in the study. And this is a blinded placebo randomized trial, meaning one patient may get the study medication that I'm going to tell you more about, and another patient will get a placebo, which is just basically salt water. And the researchers won't be able to tell what medication or if they're getting placebo. So that's a blinded part of it. And if something's going wrong with the trial, the company and the data safety committee will stop it. Next slide. So the medication being tested in this study is designed to help blood clot. When somebody suffers severe trauma and is bleeding to death, they go into shock, and going into shock causes the blood to not clot appropriately. And even though you may take the spleen out, patch the liver, sew up the bullet holes, the raw surfaces will continue to bleed, and patients can bleed to death because it's like being a hemophiliac. Their blood just won't clot anymore. And if this medication proves to work, it will save lives, and it will likely reduce the transfusion requirement that a lot of patients get. We hope that if the patients get this medication, they won't require as much blood products. Take it easy on the blood bank. Next slide, please. So this medication, the commercial name is called Kcentra, and it's been around for at least 20 years, and it was designed to be given to patients that are on blood thinners and they're having bleeding complications on the blood thinners. And it's been proven to be a very safe medication in those patients, and it was just a natural extension to want to give this medication to trauma patients. Next slide. So the inclusion criteria, you have to be at least 15 years of age. You have to weigh at least 110 pounds. You have to have confirmed or suspected major bleeding. And you need to have received at least 1 unit of blood already. And you have to go on what we call the massive transfusion protocol. If you're bleeding to death, Erlanger mobilizes a tremendous amount of blood products so we can resuscitate somebody until we can stop the bleeding. So that's called our massive transfusion protocol. So you have to be on that before you're going to get the medication. So it's pretty certain that you're bleeding bad if you're going to be enrolled in this study. Next slide. The exclusion criteria are if you've been getting CPR, if you got a bad brain injury, if you have a bad burn, if you've been on a blood thinner, or you have a history of a blood clot, or prisoners and pregnant women are not, they're excluded from the study. If we know that the woman is pregnant, they won't be enrolled in the study. Next slide. So since this study is intended to treat patients that have severe bleeding, there isn't time to get a consent. Like normally if you're going to be in a study, the researcher explains the study to the patient, and the patient can decide whether or not they want to participate in the study. Since this is happening real fast and the study medication needs to be given within 45 minutes arriving to the hospital, it's just not practical to think that we can get consent from patients like that. And the FDA has realized an importance to be able to do research in patients that have life-threatening conditions. So there is a thing called exclusion from informed consent, or EFIC. And that is some regulations that the FDA has established. Next slide. Next slide. Trying to move through this. Part of the EFIC protocol for the FDA is to go out into the community and educate the community about this study that will be conducted at Erlanger, so the community will be aware. It's extremely unlikely that anybody you know would be involved in this study, but we want you to know about it in case that were to happen. And after you're enrolled in the study, at whatever time point we can talk to the family or the patient is able to understand that they've been enrolled in the study, we'll explain the study to the family or the patient or both. And if they decide they don't want to be in the study, you come out of the study and you're not in the study anymore. So once you are informed and you don't want to do it, then we just take you out of the study, and there's no problem. Everything else is the same. Once you get this medication in the trauma bay, that's all the study, that's all that's involved. There's no other drugs, there's no other medication. We just follow you out to 30 days, and we're looking, the main outcome from the study is mortality. We want to know what the mortality of everybody in the study is at 30 days. Next slide. And so The main point I want to stress this evening is if you don't want to be in the study, if you say, that's not for me, then that's fine. There's a way to opt out. Next slide. So there's a link down here at the bottom that if you go to Erlanger, you can find this link and you can get instructions on how to opt out. But basically, you get to wear a bracelet and on your wrist, and if you come in the trauma bay and you got the opt-out bracelet on, we'll know this patient does not want to be in the study, don't give them the study drug, and that's fine. Everything else will be the same. It'll just be like Erlanger's not doing a study, and no one will be included that's wearing the opt-out bracelet. If you like the idea of Erlanger participating in the study, trying to do research, trying to find a way to help patients, there's a survey and you can give your opinion about that, or if you think Erlanger is pushing the envelope too hard and that this community should not be in an ethics study where you don't get a chance to give consent, then you can also express your opinion. It's completely anonymous. This information all goes back to the central headquarters is at the University of Alabama in Birmingham. They have a major research center there. And if there's enough concern about this study being conducted, then they would have to take that into consideration about whether or not Chattanooga should be in this study. So that's all I have. I don't want to take up any more time tonight. I know you have a great stroke program lined up tonight, but if there are any questions, I'd be happy to answer them. Okay, you gonna let me off easy? Well, I sure appreciate your time, Sonia. Thanks for having me down here too.
All right, thank you, Dr. Maxwell. Dr. Mance, you ready?
Yeah, I'm ready.
All righty. We'll turn it over to Dr. Mance and the panelists. Thank you.
Good evening, everyone. My name is Cornelius Mance. I'm a practicing neurologist in Chattanooga and Hickson, Tennessee, based in Chattanooga since November 1983. So I've trained at Erlanger from 75 to 77 internal medicine. Then I went back to Memphis where I did my neurology residency. I finished in 1980, and I moved here November of 1983, and I've been here ever since. So basically, I'm a clinical neurologist that basically deals with multiple neurological diseases. So that's basically who I am. Each one of the speakers will basically tell who they are. Dr. Gibson, which is my partner, and also Dr. Cleopatra Thurman, which is, she's a newcomer to this area, and she's at Erlanger, so she will tell you who she is and her qualifications. We came up with this talk concerning stroke, and I think many people need to ask the question, who do they know who have had a stroke? The next question you ask, do you know what to do to decrease the number of brain cells are dying every second or every minute if you have a stroke? And also the criteria that will include you into this process that will decrease this, or you can be an outlier which you cannot receive certain medications. And what happened is that we have to understand more about the importance of this because how many people are having strokes. In 2021, 1 in 6 deaths from cardiovascular disease are due to stroke. Every 40 seconds, someone in the United States experiences a stroke. Every 3 minutes and 14 seconds, someone dies from a stroke. When you think about that, that right there is astronomical, which we talked about drugs and things like that. Every 12 minutes, someone dies from opiates. Every 6 minutes, someone dies from alcohol. And so what happened to us, this disease is very prevalent. Annually, more than about 800,000 people in the United States suffer stroke. Approximately 600,000 of these are the first time having strokes. Of the ones that this is 800,000, 185 strokes, nearly 1 in 4 carry an individual who has had a previous stroke. So that tells you that this disease is not without consequences or morbidity and mortality. Approximately 87% of all strokes are ischemic strokes, where blood flow decreased to the brain. Stroke-related costs in America is about $56 billion per year between 2018 and 2019. And what we're seeing is that cost is gradually increasing. Even though we may be seeing decrease in the number of people who are having strokes, in this case says strokes is the leading cause of serious long-term disability, affecting more than half the people who have strokes age 65 or older. As that group may be decreasing, but the younger people begin to have more strokes. Therefore, we have greater demand on the system because of disability and the length of life. The average person who has strokes, according to how severe the disease, their life expectancy may be 10 to 15 years. So it's not without certain morbidity and mortality. You think about the risk factors for stroke: high blood pressure, high cholesterol, smoking, obesity, diabetes are the leading cause. If you go back to this, you recognize that the major cause for all of these diseases related to lifestyle change, in which we in America has a standard American diet. We also on an extreme amount of stress. We also do not rest. We constantly do not exercising. We become couch potatoes and everything else. What happens is that if we can change our lifestyle, and also we think about the 3 C's. You must have clean water, clean air, and clean food. If you can be able to do those things and decrease stress, which means that you will decrease your risk factor. We recognize that with strokes, we were talking about tonight, in which Dr. Gibson and Dr. Cleopatra Thurman will be talking about, early action is crucial when stroke symptoms occur. Recognizing warning signs and seeking emergency treatment, prompt improvement for survival. And that's one of the most important things, is survive and have less disability. Age is a significant risk factor. While stroke's risk increase with age, stroke can happen to anyone. In 2014, 38% of hospitalized stroke patients were under the age of 65. Race and ethnicity play a role. Non-Hispanics and Black patients have a higher risk of having their first stroke compared to white adults. And with us understanding this, that tells us that we have a lot of work to do to be able to decrease this effect in our nation. Stroke is the second leading cause of death worldwide. It was the third leading cause of death and disability. The approximate global cause for stroke exceeds $721 billion, 66% of the global GMP. So we tell you that there's a loss of disability and loss of suffering associated with strokes. So the importance of this is for us to be able to educate the community. And I'd say one of the most important parts of all physicians is to be a teacher, to teach people how they can improve their lifestyle and decrease their chances of having a stroke. So we will turn it over to Dr. Gibson, who will give you the clinical presentation of stroke so you can be aware, so you can have rapid response.
Hello. Ooh. Sorry. I'm Dr. Larry Gibson. I'm a private practicing neurologist. Work with Dr. Mance. Medical school training at Indiana University in Indianapolis. Did my internship and neurology residency at Medical College of Virginia in Richmond, Virginia. My wife and I moved here in 1989, joined Dr. Mance in practice. We've been together since then, and basically practice general neurology, seeing basic general neurological illnesses, including stroke. Excuse me. Definition of stroke. What is a stroke? Stroke is a sudden injury or damage to an area of the brain due to impaired or disrupted circulation, also known as a brain attack. There are different types of stroke. There's ischemic stroke, which is, as Dr. Mance mentioned, the most common type of stroke and represents about 80 to 85% of all strokes that present. Can you all hear me okay? Of all strokes that present to the hospitals. Ischemic strokes basically result from blockage or lack of circulation to an area of the brain, and generally as a result from atherosclerosis or hardening of the arteries, large arteries, major vessels of the brain, or the smaller penetrating arteries of the brain. The other cause can be from embolic strokes, which typically may be from cardiac disease, particularly diseases like atrial fibrillation. Embolic strokes tend to happen suddenly and tend to be somewhat large in general. TIAs. TIA is, or transient ischemic attack, sudden onset of transient neurologic dysfunction that's caused by focal brain, or we also include the eye or spinal cord ischemia. However, it does not result in infarction or stroke. TIAs are often referred to as mini strokes. Typically, the symptoms may last less than an hour, but they can last up to 24 hours. MRI scanning in these patients are negative. There's no evidence of a stroke in these patients. Basically, the symptoms come and go. They can be considered as a stroke warning, and essentially it can be a good thing because what do warnings do? Warnings tell us that something's about to happen. And with TIAs, this is a good time to be evaluated to see if you can head off the possibility of a more permanent stroke. So those who have a TIA, about 20% of those people will have a stroke within the first 3 months, and half of those usually within the first couple of days. So again, it's an important warning, not to be ignored. It gives a good opportunity to present, be evaluated, see what your risks are, and deal with that. Intracerebral hemorrhage is the other types of strokes, and basically represent or caused by bleeding, either directly into the brain itself or the surfaces of the brain. You can have subarachnoid hemorrhages or subdural hematomas. These result from rupture of cerebral vessels, either from weaknesses within the vessels themselves. Excuse me, there's a disorder called cerebral amyloid angiopathy in which the vessels are weakened, and so they're subject to breaking and bleeding. Hypertension, extreme hypertension can be a cause, certainly cerebral aneurysms, and then you have trauma. Bleeding, cerebral hemorrhages can be very sudden and abrupt, catastrophic in the case of subarachnoid hemorrhages, or they can be more subtle and slow in the case of subdural hematomas, in which, say from a blunt head trauma, the bleeding can be very slow, leaking into over the surface of the brain, and can leak over the course of days or even weeks before that person develops symptoms enough that they present for evaluation. So clinically, strokes can result in a variety, in a variable degrees of disability. There's a scale called the modified Rankin scale, in which stroke deficit can be graded. Grade 0 is no deficit and no symptoms. Grade 1 can be no significant disability, despite the patient may have some residual symptoms, but they're mild enough that they can still carry on daily activities without much of an issue. Grade 2, there's slight disability in which they may have some difficulty in carrying out their usual previous activities, but generally can remain independent in functioning and living. Grade 3, this is again a moderate severity and requires more assistance. They can perform ADLs, but they still maintain the ability to walk, generally without assistance. Grade 4, again, more severe disability in which generally they will require assistance for performing ADLs. ADLs is activities of daily living, so things like bathing, dressing, driving, and so forth, but require assistance. Grade 5 is more severe disability, and these are severely disabled patients who generally are bedridden, nursing home type patients, and then grade 6 is death. So what are some of the clinical presentations of stroke. We've all seen the billboards and the advertisements about, initially they came out with the FAST mnemonic. Now it's Be Fast. They keep adding letters. People aren't going to remember what these are. But now it's Be Fast, and basically the B stands for balance, E stands for eyes, F for face, A for arm, S for speech, and T for time. And again, these are things that just try to help people recognize symptoms of stroke as quickly as possible, because time is brain, and time is of the essence in getting patients to appropriate treatments to now where there's more sophisticated treatment options that can actually save a person's brain. So some of the presentations of the stroke really depend upon the size and the location of the area of the brain that's involved. Speech can be slurred or people describe as thick-tongued, or that person may have difficulty expressing themselves or comprehending, so they may appear confused. You know, they're trying to talk, they can't say the words they want to say, or you're talking to them and they can't comprehend what you're saying, so they may appear to be confused. Weakness or numbness on one side of the body or the face, facial drooping, clumsiness or impaired coordination, particularly on one side, or that person may just be off balance. They're walking, but they're staggering, and their balance just isn't normal. Vertigo, particularly if vertigo comes on very suddenly and severely with vomiting, should be considered a possibility of a stroke in these instances, particularly if it's associated with headache. Those people need to be seen immediately. Sudden severe headache it is more generally associated with cerebral hemorrhages, but sudden severe headaches, especially people who describe their headaches as the most severe they've ever experienced, again can be the result of a cerebral hemorrhage. Can be catastrophic, but these are people that need to be seen immediately, and especially if their headache is associated with mental status changes, they're confused, lethargic, or basically just have a sudden change, they need to be seen immediately. Vision changes. Vision changes can be a bit more subtle. A person can have loss of vision in one eye. Now that's not a stroke itself, but if a person has a unilateral vision loss, we consider that to be more of a TIA type of symptom or stroke risk, because it suggests that there is vascular disease on that one side, and the clot or the debris could just as easily have gone to the brain as it did to the eye. So it's considered to be a stroke risk. So unilateral blindness, sudden blindness is considered a stroke-like symptom. Excuse me. Strokes that involve the visual part of the brain, the cortex, can be more subtle, because what it does is it affects one half of the vision of each eye. So a person may not really notice that they have a visual change. They may notice that something is different. We hear that they feel like there was something in their eye, or they may start to bump into things on their blind side, or we've even seen people come in the hospital because they've had a car accident because they didn't see something coming up on their blind side. So sometimes those types of strokes, those people may wait days or even weeks before they come in and figure that something has happened, and lo and behold, they've had a stroke in their visual cortex. So those can be more subtle. Again, time is brain. Initial evaluations. Again, emergency room evaluation initially involves an urgent head CT scan and what's called a CTA, looking at the circulation, and these are used to try to determine if there are potential options for more sophisticated treatments that Dr. Thurman will talk about. More routine stroke evaluations after the person has been evaluated urgently. Generally, we'll get a follow-up MRI scan, carotid ultrasound, echocardiogram. They'll get an EKG, again, looking for things like atrial fibrillation. Labs, including blood count, blood chemistries, blood glucose, lipid panels, and so forth. So these are all included in stroke evaluation, looking at the risk factors and then deciding what their secondary prevention treatments need to be. Treatment of stroke after a person has had a stroke, secondary prevention includes managing risk factors that Dr. Mance already talked about. and then appropriate medications depending upon their evaluation findings. Atherosclerosis, using antithrombotic medications like aspirin or Plavix, or anticoagulation medications in the case of those who have, say, atrial fibrillation. So I'll leave it there, and I'll go ahead and let Dr. Thurman talk.
Dr. Thurman.
Okay. Good evening, everyone. Thank you so much for taking time out of your schedule to come and listen to this talk. I feel very honored to be here to talk to you today. My name is Cleopatra Thurman. I'm a vascular neurologist. So I did my training in Michigan. I went to medical school and undergraduate at Michigan State University. Did my residency training through a hospital called Sparrow Hospital, which is affiliated with Michigan State University. Then I did my specialty training in vascular neurology, which means that I wanted to learn more about caring for patients that come in with stroke symptoms at Mercy Health in Grand Rapids. This fellowship was also affiliated with Michigan State University, so part of me, you can tell that I'm a Spartan at heart. I've been asked today to talk about advancements in acute stroke care and what to expect when you come to the hospital. This is an important subject, and it is very dear to my heart because I see patients that come into the hospital, into the emergency department with acute stroke symptoms, and I watch them struggle as we ask them to give informed consent about therapies that we're offering them to try and help decrease their disability. Because for them to participate in this decision, we have to tell them what the risks are of that therapy, right? And sometimes that risk can cause such fear that patients decline therapy, or they decline for their loved ones to get this therapy. But this is standard of care. It's what we have to help decrease your disability to make sure that you can improve and be independent again. Next slide. So as we've already heard, because of these acute therapies, stroke actually dropped from being the 3rd leading cause of death to the 5th leading cause of death. But unfortunately, even if we're doing such a good job in stopping people from dying because of stroke, stroke still remains the leading cause of disability worldwide. So people are still, requiring a lot of help because they had a stroke, which leads to all the things that Dr. Mans talked about. The more care that you need, the higher the burden on the healthcare system is, and it takes away your quality of life. So these acute therapies have been implemented to decrease disability and to allow for you to live with good quality of life. Next slide. So these are some of the risk factors that have already been discussed that can lead to stroke. And I won't go over this again because we just discussed them. Next slide. And this is our wonderful Be Fast mnemonic to help people in the community recognize signs and symptoms of stroke. These include balance. If you see somebody who was fine just walking a straight line, going to work, or going to the bathroom, all of a sudden they start walking like they're drunk or off balance. They can't stay straight even if their strength seems intact. That could be a symptom of stroke. If they're having trouble with their vision, they can't see out of one eye, or they can't see one half of their world, or they're describing that they have double vision, this is a symptom of stroke. If you look at their face and they have a beautiful killer smile, but all of a sudden it's drooped on one side, that's a symptom of a stroke. If they have weakness in an arm or a leg, that's also a symptom of stroke. In addition, if they have trouble with their speech, so they're talking to you and all of a sudden they start to sound drunk, so the words are coming out, but they're very slurred, or they're trying to produce language and it's choppy, or you're asking them to name things and they're saying things that don't make sense at all. The words could be coming out completely fluent, but it doesn't make sense. For example, somebody is trying to say, "Can you pass me that cup of water?" And they say, "There was a monkey down the road 6 times. Like, that doesn't make sense. Nobody talks like that, right? And it happens very suddenly. These could be a sign of a stroke. And what you need to do is call 911. That's what the T stands for. You want to call 911 because, one, we train our paramedics to help triage patients that are having stroke-like symptoms. They know based on your symptom what type of stroke you might be having or the kind of treatment that you might benefit from. So it helps them decide what hospital to take you to. Should we take you to a primary stroke center, or should we take you to something called a comprehensive stroke center based on your symptoms? And they can drive faster if they switch on their light to get you to the hospital versus you trying to drive your loved one. Just imagine you're in a panic. Your dad, your brother, your sister was fine. Now all of a sudden, their arm can't move, their leg can't move, and you're trying to beat every traffic light as you drive while watching your loved one continue to deteriorate. That's very anxiety striking. You're not going to do a good job because you're not in the right frame of mind. So you need to call 911. And God forbid you try to drive yourself. That is not a good idea. So we always advise that you call 911. Next slide. So why is it important to talk about acute stroke therapy, right? So let's take a look at some numbers from Erlanger Hospital. So between June of 2022 to June of 2023, this is a 24-month time frame, we took care of 1,576 patients that came in with stroke symptoms. Of that 1,576 patients, 228 of those patients got something that we refer to as a clot-busting medicine. And I'll go over what this is and what it does for you. An additional 161 patients got additional therapy called mechanical thrombectomy. Now, I can't add those two numbers and say that we were able to offer 389 patients, or about 24% of these patients, acute therapy because there's an overlap. So less than 24% of patients actually got acute therapy. Well, why is that, right? That's a lot of people to have presented to the hospital and not receive acute therapy. So some reasons that we were able to find when talking to patients and just looking at our data is that patients didn't get to the hospital on time. What I tell people is that when you're having a stroke, the thing that allows you to think, your brain is not functioning. So most people don't really think to say, I need to get up and go to the hospital, right? They think, I'm gonna get better. And so it's up to you as an educated community member to recognize that these are signs and symptoms of a stroke and to call 911. Some patients got to the hospital on time, but there's something called a stroke scale. And when we performed that, it was rather low. And perhaps their symptoms just were not bad enough that we felt that perhaps if we gave them these therapies, they might do worse. In some patients, the family or the patient themselves refused. Some people, their symptoms were just getting better so quickly that, again, we thought that they, in the end, will do well even if they didn't receive this therapy. And sometimes we didn't know when their symptoms started, which is a very important thing when it comes to acute therapies in stroke. And some people were in blood thinners, so they didn't qualify for therapy. But two things I want to point out on this slide is the fact that patients didn't get to the hospital on time. That's something that we can change. By recognizing stroke symptoms, we can get patients to the hospital on time so they can receive therapy. Family and patients often refuse therapy because, one, they either don't understand what the prospect of benefit is, or they're so overwhelmed by hearing what the risks are that they think, I shouldn't be taking that chance. But we're asking them during a time when they're very stressed, they can barely figure out what's going on. So that's why we think it's very important to come out to the community, to educate you about these therapies so that you can educate other people and you'll be better prepared to make that decision should this unfortunate event happen. Next slide. So there are two types of strokes, like Dr. Gibson already talked about. Is an ischemic stroke and hemorrhagic stroke. So hemorrhagic stroke is when a blood vessel bursts, or sometimes you can have something called an aneurysm that makes the blood vessel weak and that causes the blood vessel to burst, or you can have disease of the blood vessel itself, making it weak and causing it to burst, or elevated blood pressure. Now, I don't have enough time to talk about both of these types of stroke, but there is acute therapy for hemorrhagic stroke. However, I'm going to focus on acute therapy in ischemic stroke, which occurs because there's obstruction of the blood vessel. So for some reason, you have a blood clot that's sitting in the blood vessel in the brain, and it's stopping blood flow to an area of the brain, causing brain tissue to die. That's what an ischemic stroke is. Next slide. So, what should you expect when you come to the hospital? Next slide. The first thing that we do is we take a picture of the brain. This is called a CAT scan, and it can give us information about the health of the brain tissue. So you can see we have a normal scan in the top right corner. That's what your brain tissue should look like. These are patients, if they have the focal symptoms that we talked about, can likely benefit from our acute therapies. At the bottom left corner, you see that white stuff that's in the brain. That's blood. We don't treat these people using these treatments that I'm going to share with you. The other slide shows an area that's kind of dark, right? So for that to look that dark on a CAT scan, it means that brain cells have been dying for a while, and that this tissue is already dead and will likely not benefit from these therapies. In fact, if we do these therapies, we may cause harm, like bleeding into that area, and then that would make your symptoms worse. Next slide. So now let's talk about the acute therapies. So I've been going on about this clot-busting medicine. What is it? There's two types of clot-busting medicine, alteplase or tenecteplase, depending on which hospital you go to. They do the exact same thing. One is perhaps a little cheaper than the other, but that's neither here nor there. But you hear physicians tell you that, you're within a time window. So if you come to the hospital within 4.5 hours from symptom onset, so this is not 4.5 hours from the time that you get into the hospital, or 4.5 hours from when somebody found you with symptoms. It's 4.5 hours from when your symptoms started. So for example, if you were with someone at lunch at 10:30 in the morning, and the person can say, we were having lunch, she was completely fine, and then suddenly her words became slurred, she had this facial droop, and she dropped the fork as she was eating, right? Then I would say at 10:30, that's when your symptoms started, and that's when your clock starts ticking for acute therapy. Now, if the last time somebody saw you normal was last night, you went to bed and you wake up at 6 o'clock in the morning, you've been sleeping since 2100 last night, nobody has seen you get up, go to the bathroom. Unfortunately, your clock starts ticking at 11 p.m. last night when you went to bed. This is the type of person that when they arrive at the hospital, we may say they're outside the window for clot-busting medicine. What does clot-busting medicine do? So you can see on the far left, it might be your far right, because obviously I'm turned around. There's a blood clot sitting in the brain. That blood clot is preventing blood from getting to tissue, and tissue is dying. From the minute that blood clot sits there and blood isn't flowing through, tissue starts to die. So through an IV line, we're able to put a line in your arm. We can give you this clot-busting medicine. It goes to all the vessels in your body, but also the vessels in your brain. When it encounters a blood clot, it's able to break it up and dissolve it, and it allows blood to start flowing again. Our goal is to save as much healthy tissue as possible, because this is what causes you to improve and recover, okay? So if we leave that blood clot sitting there, brain tissue is going to die. The more brain tissue that dies, the more disability you have, the less the chance for recovery. Next slide. So this is what we oftentimes use to talk to patients about recovery and how this clot-busting medicine helps. So if I give this clot-busting medicine to about 100 people, 13 of those 100 people will end up being normal or nearly normal. So close to where you were before that blood clot ever got into your brain, okay? 32 out of 100 people will be better than they would have been if they got nothing. This is where the holdup comes, is about these 3 people at the bottom in red. So these 3 people at the bottom in red might do worse for several reasons. One, the medication might just not work, and that clot will go on to be whatever it was meant to be, and you're going to end up with disability. But sometimes it can be because of adverse effects, right? So we're giving you a medicine, or medicine has some risk. So some people might bleed into the brain because of this medicine, and their symptoms would be worse. Or you could bleed into some other area, like the abdomen. If you had maybe you already had a slow bleed that was going on, you might bleed into that area, and because of all this blood that you lose, you might do worse, okay? And then 1 out of 100 people might end up with a poor outcome because maybe they bled really badly into the brain that their disability was worse, or sometimes they could even die. So this is a risk, and we have to share that with you as we tell you that we're going to give this medication to you, right? Because nothing comes without risk. I mean, we take a risk every day. You walk out the door into the street, you're taking the risk that you might get hit by a car. It might not happen, but it's a possibility. So same way, but is this risk worth taking? It is, because this is what we have as standard of care to decrease your disability. Next slide. What if you come to the hospital and it's after this 4.5 hours, or we give you the clot-busting medicine and it doesn't work? You say, well, Dr. Thurman, is there anything else you can do for this patient? Next slide. And the answer is yes. So in addition to just looking at your CAT scan, next slide, we also take a look at your blood vessels. So you can see here, these are blood vessels in the neck going into the brain. So we can look at these blood vessels to see if we can actually physically see a blood clot that's sitting in one of the major vessels of the brain that are big enough for us to go in with a wire and pull this blood clot out. Next slide. So this is an example of what we can do for you. So we go in through the groin or through the wrist with a wire up into the brain. You can see all the way to the right, there's a blood clot. I honestly wish I could stand or had a pointer. There's a blood clot sitting in the brain. I'm going to stand up. Thank you so much. So mechanical thrombectomy is actually indicated up to 24 hours from when your symptoms started. We may have to do some fancy tests to determine whether or not you're going to benefit. Next slide. So so every minute that goes by, about 2 million brain cells are dying if we don't open that blood vessel and restore blood flow, okay? But we can make this decision not only based on time, we can also make it based on advanced imaging that are going to tell us about the health of the tissue. Next slide. So this is a fancy image called a perfusion scan, okay? This can tell us about the health of the tissue. What I have here is an example of a normal CT perfusion. So you can see on the on this left side, this is going to be telling us information about brain tissue that has died, whereas this right side is going to be telling us information about brain tissue that we could potentially save. And I'm going to show you examples of this. Next slide. So this is an example of a patient that's coming in. This picture here shows you that they have a blood clot in the brain right here. And when I look at it, and I look at the left half, you can see that here it says 0 mLs, meaning no brain tissue has actually died up until this point. However, if I leave that blood clot sitting in the brain, this half of the brain, the stuff that you see in green, is brain tissue that actually is going to die. And our goal is to try and save that brain tissue by performing things like mechanical thrombectomy. Next slide. Then here is an example of another person that's coming in, maybe 5-6 hours from when their symptoms started. This purple stuff that you see is brain tissue that has already died, okay? I can't save that. However, this green stuff is showing me this brain tissue that has died and additional brain tissue that is going to die if I do nothing. So if I subtract this 46 from this 111, it tells me that 65 mLs of brain tissue is tissue that I can save, and that's a lot. And so it tells me as a provider that I should offer you this therapy to save this brain tissue so that in the end, you can do better. Next slide. Then this is an example of brain tissue that, again, has died in purple, and brain tissue that is going to die. However, when you look at this number, 217, in comparison to this 229, if I subtract the brain tissue that has died and brain tissue that I'm going to save, I remain with 12 mLs. This isn't a lot of brain tissue that I'm going to save, and this is a huge area of brain tissue that has already died. If I open that blood vessel up, there's a risk that you might bleed. Think of dead brain tissue like a dead fruit. If you have a dead fruit in front of you and you take a hose and you spray it, what's going to happen? It's going to splatter, right? And that's what's going to cause additional injury because you're going to bleed into that area. So there might not be a benefit in offering you this therapy. Now, I can also share with you that this is changing. It's changing all the time because we're doing studies all the time, okay? Next slide. Okay, so we've talked about the fact that we can use advanced imaging to offer you mechanical thrombectomy if there's a blood clot sitting in the brain. What if I looked at your blood vessels and there wasn't a blood clot sitting there, and I can't offer you mechanical thrombectomy, and you're coming outside that 4.5-hour window, or you woke up with symptoms? Is there anything I can do to still decide to give you the clot-busting medicine? And the answer is yes. Next slide. Because we can use things like MRI imaging to decide when your stroke symptoms started. So since you went to bed at midnight and it's 6 o'clock in the morning, your stroke could have happened 10 minutes before you woke up. It could have happened an hour before you woke up. It could have happened 3 hours before you woke up. Or it could have happened at midnight when you went to bed. I need to decide if it's close enough to that time that you woke up so that I can perhaps give you the clot-busting medicine. So MRI can be used. You can see over here there's a little bit of whiteness on a sequence called DWI. You don't have to remember what these stand for, but all I'm showing you is that I can look at 2 different types of MRI images and decide based on what I see. I see nothing here, but I see something here. That tells me that your symptoms probably started less than 4.5 hours ago, and I should offer you clot-busting medicine. I see something here, and I see something here. This tells me that even if you woke up with symptoms, these symptoms probably started more than 4.5 hours ago, and giving you clot-busting medicine might cause more problems than good, and I shouldn't offer that. Next slide. Of course, I talked about this already. there's risks to these procedures. If you get the clot-busting medicine, there's a risk that you might bleed. But most people do well. This is standard of care and why we offer it, because we've done studies to show that more people benefit from receiving these therapies than harm, okay? We do have to tell you about the risks, but most people generally do well. So my advice would be that if you came to the hospital and this therapy was offered because you were having stroke-like symptoms, to accept the therapy, okay? And then, of course, medications, once, when we put anything into the body, there's side effects from it. Some people can have swelling of the throat, and this can be seen with any type of medicine that we offer patients. If you've never taken it before, there's no way for me to know that you're going to have this reaction. But this is why we have emergency medicine physicians when we're offering these therapies, so that if you need to be intubated, you can be intubated to support your airway. And if we need to give you medications to reverse these side effects, we'll give you those medications, because we do have medicines to reverse that. Of course, when somebody punctures the skin, so when they're doing mechanical thrombectomy, they're going through the groin or through the wrist, when they can puncture that artery at the site, and you can bleed, say, into the leg. If you bleed into the leg, you can bleed enough to where you might need a blood transfusion. When they go into the brain to take that blood clot out, there is a chance that they can flick some of that substance further upstream to cause a stroke, or they might puncture that blood vessel in the brain. But we don't just allow anybody to do these procedures. We allow people that have many years of training and are very confident in what they're doing, and they do this all the time, right? So our outcomes are very good. But nonetheless, we have to share that with you because they're human, and human beings sometimes make mistakes. And then, of course, I shared with you that you can also bleed into the brain just by virtue of opening that blood vessel and having this gush of blood going to an area of tissue where the brain tissue itself had already died. Next slide. Not all hospitals are equal, and this is important to understand. I'm not here to promote any hospital, but my job is to share with you that different hospitals can offer different services. Some hospitals are known as acute-ready stroke centers, meaning they can evaluate a patient, they might be able to get a CT of the head, and they might be able to give you the clot-busting medicine. But if you have a large clot sitting in a vessel, which sometimes you have to get both therapies, they might not be able to offer that. And they know to transfer you to a center that can offer you that management, okay? And so there's also what is known as a primary stroke center. Again, here you might find that they have some experts in the field, either in person or via telemedicine. So they can call someone, a neurologist, to help them make decisions. And then we have something called a thrombectomy-capable center, meaning they can provide all of this, but they might not always they meet the minimum volume for those surgeries, but they don't do these procedures as often as a comprehensive stroke center. A comprehensive stroke center, for you to get that designation, which is about 6% of all hospitals in the United States, is that you have to be able to offer all these acute therapies, and when complications occur, you have to have the staff available in-house 24/7 to take care of those complications. Sometimes patients with stroke might have swelling, and they need their skull removed so that the brain can swell out to try and save them. All those are things that can be offered at a comprehensive stroke center. When you come in with a bleeding kind of stroke, you may need surgery to take out that blood out of the brain. You need surgeons to be available at that center. So that's all that this slide is really trying to tell you. We do train our paramedics. There are certain signs when you're talking to when you're evaluating a patient that can tell you that they probably have a clot in a big vessel in the brain, okay? And that person will likely benefit from going directly to a comprehensive stroke center instead of making these stops. And so we empower and train our paramedics to make sure that they can recognize those signs and symptoms. We don't want everybody flocking to Erlanger. We want you to come to Erlanger, but if everybody did, and yet they could have gotten their care at an acute ready center, we would not have the manpower to take care of everyone. So we appreciate that all these centers are present, and we want to use them and use them appropriately so that we're giving care to as many patients presenting with stroke as possible. Next slide. So the take-home message is that if you have any of those signs and symptoms concerning for a stroke, what we want you to do is to call 911. That's the best way for you to get transported to a hospital. There's acute therapies now for patients coming in with stroke symptoms. Those include clot-busting medication, also known as thrombolytic, procedures, surgical procedures to pull the clot out, known as mechanical thrombectomy. We can use advanced imaging. If you come to a center that that imaging modality is available to make further clinical decisions about the care that you get. So it's very important because we're expanding this window of patients who can get acute care more and more based on this advanced imaging. Remember that in medicine, our goal is always to do no harm, and therefore we want you to always be ready to partner with your providers to make the right decision for yourself and for your loved ones. Next. I think that's all I have today. If you have any questions.
I want to thank Dr. Gibson and Dr. Thurman for their presentations.
Got a couple of questions. I'm not sure this, yeah, we're back. Questions from audience in Radio Land. If I suspect a loved one is having a stroke, what can I do while I wait on the paramedics to arrive?
You just want to make sure that your loved one is safe. I know sometimes people say, you know, give them a double dose of their aspirin, or sometimes if they're on a blood thinner, some people might think it's a good idea to give them a blood thinner, but it's like an extra dose of their blood thinner. But what you want to do is to call 911 because you don't know what type of stroke your loved one is having. Do they have blood in the brain or do they have a blood clot? And there's no way for you to know. That's why you need to come to the hospital so we can do this, these images and help decide what therapy they need.
Okay. Second question, if I am already on blood thinners, can I receive clot-busting medication?
No. If you're already on blood thinners, you cannot receive clot-busting medicine because this is one of the contraindications. Your blood is already thin, and if we thin it more, we're increasing the risk of you bleeding into the brain or bleeding into some other part of your body. And so you would not be a candidate for clot-busting medicine, but you could be a candidate for the mechanical thrombectomy, and that's why you still need to come to the hospital.
One of the questions that we have when you talk to patients, they look at aspirin, Plavix, Coumadin, Eliquis, Pradaxa, Xarelto. Which one are we talking about they should not receive the clot busters?
These are the blood thinners like Coumadin, Xarelto, Eliquis, or Pradaxa. So aspirin and Plavix, although in layman's terms we call these blood thinners, they really work on a completely different mechanism. And if you're on an aspirin or you're on Plavix or something called Brilinta, you would still be a candidate for clot-busting medicine.
Okay. Any questions out of the audience here? Questions? Certainly, we appreciate the panelists for their being here tonight and discussing this stroke mechanisms. Got something, Dr. Mass?
There's one question I can ask Dr. Thurman. One's called cryptogenic stroke. I think many people don't understand that one, in which you have a stroke but no particular cause. But then we think about, could a person have silent irregularities in his heart? Maybe Dr. Gibson could talk about that one.
Yes, generally these people, when you evaluate them, their arteries are clean, Basically, all the diagnostics that you do are clean, and you just really don't have any obvious reason or cause for their stroke. So these are strokes we call cryptogenic. These patients, may have cardiac issues like atrial fibrillation that comes and goes, and we're just not catching it. So some of these patients need to be monitored over longer periods of time to see if that's what's going on. So these are patients that sometimes may get monitors for more long-term monitoring to see if we can try to figure out what's going on.
Any other questions? Again, thank you all for being here tonight. We have 2 more of these series, January, February, correct?
Oh, February.
All right. Well, hopefully January too. If not, maybe March. These are very important. Tell your friends, tell your family. We have some very good discussions on these Thursday nights. And it's very important, especially to the African American community. We need to understand the seriousness of these type of illnesses. So tell your family, tell your friends, tell your church folks, okay? Let's get this house filled. We had about 40 people on live stream tonight. Okay, great. So that was a great audience also. But we want to fill this room, okay? Thank you again for being out here. Hope you can stay warm on your way home. Good night.
Thank you, my dear.
Thank you.